We'll just start by introducing ourselves. My name's Dallas. I'm a medical content advisor with Sketchy. Um, I did medical school and internal medicine residency at the University of Pennsylvania. So I was in Philadelphia for 7 years, and then actually for an eighth year as a hospitalist at the Philadelphia VA, while my wife was wrapping up residency. And then we moved back to the New York area. I'm in Jersey, but I'm in New York for training. I'm a pulmonary and critical care fellow at Columbia. And fun fact, I'm graduating fellowship in a week, and I'll be working doing pulmonary hypertension with a health system in the area.
That's really exciting. I'll go ahead and introduce myself really quickly. My name is Myra Aquino. I'm a senior content strategist at Sketchy. I basically work with the Sketchy team to create all the sketches the students know and love, along with creating the cases that you're going to be trying out today. I went to med school at the University of Miami, where I got my MD and my master's in public health. I realized I really wanted to be in tech. I was lucky enough to find Sketchy. Um, I guess like we were putting in our memorable rotation story, but for me, it was during my pediatrics rotation. I was in the ER. And a mother comes in super concerned because her 16-year-old in the afternoon was very difficult to rouse and super lethargic and just wasn't responding to anything that she was telling him. And so she brought him to the ER. And the ER doc, the PDR doc, basically took one look at him, did a really quick exam, saw his red eyes, and basically said, "Ma'am, your son is super high on weed and he just needs to sleep it off." And she was like an immigrant mother. She had no concept of what any of that was. And so I just thought that was just like a really interesting, one of those like slice of life stories you get in the PTR that doesn't necessarily have to be super exciting, but it's just one of those things that you realize like everyone's human and anything can come through the door. That's on me. And yeah, I'm sure like everyone has their own favorite rotating stories or they're going to have ones coming up soon. And we'll be covering a case today as well.
Yeah, you talk to a lot of people. I think I have a lot of memories from clerkship here, so it can be nerve-wracking, but it's also exciting. So we're going to start by talking through some really practical tips for succeeding on your internal medicine rotation, what to expect as a member of the team, and how to start building your skills for your differential diagnosis and presentation. And then we'll actually go through a case, hopefully give you guys a sense of how you can use Sketchy as one tool to sort of build your history, physical exam taking skills, and then sort of work the differential building muscles as well. And then we'll do a little debrief and a Q&A session at the end of the case. So internal medicine is a sort of very cognitively demanding specialty by nature of how many systems internal medicine covers. There is a lot to learn. There are many sort of nuanced, sort of interwoven medical conditions that require a really deep understanding of what's going on, not just with the individual sort of conditions, but also in how they interact in sort of the context of your patient. You're going to encounter a lot of new information and a wide range of pathology, which again is very exciting, but can also be nerve-wracking as a new clerkship student. At the beginning of your rotation, and I think throughout the year, you'll find that there's a focus on history taking and the physical exam, which in about 80% of cases will actually get you to your diagnosis. So building those skills is really valuable. Your team will also want to see your clinical reasoning skills and your presentation skills, and those kind of go hand in hand. Because your presentation skills are ultimately how you communicate your clinical reasoning to your team. Internal medicine is a team sport, so you're going to have an attending, you'll have senior residents and interns, and even though it may not always seem like there's a clear role for you. I promise that it's a busy team and they're really happy to have your help and to have your sort of have you as a member of the team. You're going to have a fair amount of time during the day where you can speak to patients and then also to your family, to their family members. So that can include counseling, education, and even just gathering more information after they're initially admitted. So really take advantage of that. You'll probably never have as much time to talk to your patients as you do when you're a clerkship student. Your role on the rotation is going to evolve over the course of the year. Even at an early stage, where I don't know if you guys have heard of the RIME model for thinking about learning in a clinical setting. Um, but RIME stands for reporter, interpreter, manager, and educator. And the idea is as you progress through your education, you sort of ascend the RIME model to eventually become the educator who's mastered the earlier three steps. Um, in that reporting stage where you're gathering, information during your history and your physical exam, you're actually starting to show your team your clinical reasoning because the information that you're gathering communicates what exactly you're thinking about as you're speaking to that patient. Um, Being efficient, organized, and logical goes a long way in making sure that you gather all the information you want to support what you think is the most likely diagnosis when you're interviewing patients. Um, and like I mentioned, tailoring your reporting demonstrates your clinical knowledge. It's important to set expectations early on, because even though you may have worked with teams in the past that have certain presentation styles and preferences, I think Myra can attest to the fact that people are very different in their clinical style in the hospital, and you'll find that going from one team to the next, there can be very, very different expectations. And so just meeting with your attending and your senior resident early on to get a sense of what's expected of you, sort of on rounds and then after rounds, can really go a long way in sort of setting the framework for a successful rotation. You're not expected to know everything on internal medicine. And I'll say as a resident and now a fellow that's worked with many students, when people ask you questions, if you don't know something, it's not like a sign of weakness. And in fact, I'm sometimes excited when people tell me that they don't know something because it gives me an opportunity to teach something that I'm excited about. And I'll say 90% of the time that I've seen residents or attendings ask questions, it's more to probe to the level of knowledge that you already have to know how they can best teach to your level and to make sure that they're not already sort of teaching you something that you have a great understanding of. Outside of teaching that you'll do with your residents and your attendings, point of care and post care learning is a must. So, spend some time finding the resources that you enjoy learning from. We hope Sketchy can be one of those platforms. Sketchy, as you'll see, gives you a great opportunity to not just practice sort of history and physical exam taking, but also comes with pretty evidence-based learning points and then resources at the end of the cases for further reading. And then looking at primary and secondary literature can go a long way as well. And we'll talk a little bit about the difference between primary and secondary literature sort of as we go on. Study and read on your patients as your rotation goes on with the goal of both sort of passing your shelf or your comat and then also delivering great patient care. You'll find sort of as you do practice questions for boards or for step one, a lot of the vignettes will sound like patients that you see in the hospital. And it's because a lot of those questions are based on real cases. And so the studying does not have to be studying for patients and for boards does not have to be sort of exclusive. You can learn for both, doing both. When you're first starting out, and you don't have sort of well-constructed frameworks for thinking through the most common uh, issues or diagnoses in internal medicine, illness scripts can be a really helpful way to start that pattern recognition building where maybe you don't have like a very clearly defined framework for shortness of breath, for example, at the beginning of your rotation or at the beginning of your clerkship year. But as you go along and you encounter specific conditions that can cause shortness of breath, you should start to be thinking through the risk factors for specific diagnoses that can cause shortness of breath, other signs or symptoms that you might expect when you see people with these individual diagnoses, and then how you would either rule in or rule out that diagnosis with your physical exam, with additional diagnostic testing, and then ultimately how you would treat the condition if you came to that diagnosis. So you may not have illness script at the very sort of beginning of your clerkship year, But as you go along, even if you don't do this intentionally, once you see enough patients with heart failure, you will have your illness script for heart failure. Once you see, enough patients with DVTs, you'll have your illness script for DVT, which stands for deep vein thrombosis. When you're just starting out, keeping a broad differential, which includes multiple systems, is important because it makes sure that you're not prematurely excluding potential diagnoses, and also helps make sure that you're asking an appropriately broad set of questions when you're interviewing somebody. You can start to narrow your differential even before you walk into the room now with the electronic medical record. You'll find that your residents are doing what they call a chart biopsy, and that can start with something as simple as looking at vitals. And those vitals can clue you into whether a patient is sick or not sick. And I'd say learning to differentiate sick from not sick is sort of one of the strongest skills you can build during your clerkship year. And just from that sort of sick or not sick categorization, you can start to rule in or rule out certain diagnoses. Going from there, once you've built sort of a pretty appropriately broad differential, you can start to think about questions that will quickly help you narrow down your differential to what you think is most likely. And then based on what question responses fit your illness scripts or help lower things down on your differential, you can really start to sort of further hone in on the appropriate questions in physical exam to get to the diagnosis that you think is most likely. You could do the same thing with your physical exam, and then after you've left the room with any imaging, EKG, and lab data that you end up obtaining for your patient. If you don't know the diagnosis before you see the patient, like I said, you really want to start broadly when thinking about your differential and then narrow down as you go and obtain more data. If it's helpful at the beginning, you can use mnemonics for building a really broad differential. The Vindicate mnemonic is one that is very commonly used, though you may also hear the vitamin B, C, D mnemonic for thinking about sort of large bucket categories of medical conditions when you're building a differential. At the end of your data gathering and when you're presenting your patient to your resident or to your team, you should always have a few items on your differential. Even if you think that you have one diagnosis that's far more likely than the other, including multiple diagnoses in your differential shows to your team that you didn't prematurely anchor on something and that you've really thought about this case comprehensively. Your team will want to know that you've gathered information that supports what you think is most likely and either refutes or makes other things that were on your differential less likely. So it's reasonable to have at least two plausible diagnoses on your differential, including one that would be sort of among the most common for your age group, and then 1 to 2 must not miss diagnoses. So, for example, if you have a patient with chest pain that's reproducible in palpation after a car accident, sure, rib fracture may seem very likely, but making sure that you're not missing something like a fat embolus or pulmonary embolus or traumatic hemothorax is also very important. Your team is going to want to hear that you've thought about those things and have sort of either appropriately ruled them in or ruled them out. Um, you want to make sure that your subjective information and then your physical exam target your differential because even before you get to your assessment and plan, your residents and attendings are going to be listening for what data you gathered to start building their differential before you get to yours. And generally, they want to hear that the information you're gathering supports what you end up suggesting in your assessment and plan portion of your presentation. If you get to a diagnosis at the time that you sort of reach your assessment and plan, congratulations, you've won half the battle. There are a couple more steps to be taken from there. So, in many cases, you want to think about, what led to the diagnosis that the patient came in with and whether any of these things are life-threatening. So, if you have a patient who came in decompensated heart failure, I'm sure you now have a diagnosis of decompensated heart failure and you know how to manage decompensated heart failure, but what led to that decompensation? Did the patient come in with a viral illness? Do they have an arrhythmia that needs to be addressed? Did they have like a new sort of ischemic event that led to sort of further compromise of cardiac function. These are all things, again, that as part of your assessment and plan, your team is going to want to hear, and really shows that you're sort of thinking at that next level as a clerkship student. And sort of going beyond that, thinking about reasonable causes, sort of for the specific clinical scenario and data you gathered, sort of go hand in hand with sort of thinking through what led to that specific diagnosis. It really shows that you can help sort of contextualize the patient and all the information you've gathered. In the workup that you suggest, you'll want to definitely rule out the potential life-threatening causes, even if you think they're less likely. You can't hang your hat on likelihood without supportive data. So making sure that you're suggesting, that you obtain some of that objective data is very important. And then also identifying the diagnostic tests to rule in or rule out those diagnoses that you think are most likely. And then your workup can sort of go extend from there into potential complications of the potential or known diagnosis, and then any sort of known medical history or findings. So if you have somebody who's coming in septic shock, for example, sure, you do your workup for the source of infection, but then you also look for evidence of end organ compromise. So is their liver function okay? Is their lactate elevated, which would suggest hypoperfusion? These are things, again, that sort of show that you're thinking not just at the level of the diagnosis, but how this diagnosis is affecting the patient, and will go a long way on your rotation. Some other tips to shine on your rotation. Being professional goes a really long way. So introducing yourself to members of the team, to nursing, showing up on time and sort of offering to help out during the day, which sort of goes along with being an active member of the team and having an active role with patients. As I mentioned, you do have a lot of time to spend with patients, so they will remember seeing you, speaking to you, and when they voice that appreciation, I think it's very rewarding, but it also sort of shows your team that you are very engaged and sort of a valuable member of the team. You want to demonstrate that you're eager to learn and showing initiative in your reading on your own patients and any other patients on the team that there might be something to learn from. And then, show that you're thinking about the patients comprehensively. So, beyond sort of the specific medical condition, what their care will look like outside of the hospital, what barriers they might have to going home or sort of managing their medical conditions on their own, shows that you're able to think about, the medicine, but also about the sort of whole patient, which is, I think, one of the really cool parts of internal medicine. Really cool, but really challenging. You should be looking at your patient's clinical trajectory and sort of pivoting in your clinical reasoning as their clinical course progresses. And your team will be looking to see that your medical knowledge and diagnostic reasoning are improving as the rotation progresses. As I mentioned, setting early expectations is valuable, but only goes so far if you're not also getting feedback on those goals and expectations. So seek feedback early and often, and look to learn from it as you go along.
I'm gonna go ahead and transition us to the case challenge, but I do want to say that, like, I think, at least in my experience when I was in my rotations, if I wasn't thinking about my patients, I was definitely doing U-World questions on the side when the doctors weren't looking. But I do want to say that early med school and the time you have in your clerkship year is the time that you can actually focus on your patients, do additional research on them, on what they have, and actually spend a little bit more time taking the history and physical. So definitely take advantage of that whenever you can. That being said, like, we have additional opportunities, like with Sketchy, you're about to go into a case, and I'll talk about it. We have a new platform called Cases. It's AI powered and AI enabled. These are cases that have been basically built and written by clinicians, and they have been reviewed by them. Dr. Argueso is one of those people. And it's basically an opportunity for students to go through a case at their home without the roving eye of your attending or the residents, so that you can actually work through a case with a patient in a safe space and give yourself the time to actually get exposure to the cases that you may potentially not otherwise get in the hospital, or if you just wanted to go through like another myocardial infarction case or anything like that. That's what we're about to go into. And so we can go to the next slide.
Oh, sorry, for some reason,
Or,
there we go.
oh,
Okay.
there it goes. So we're about to do a 20-minute crack the case challenge. The case is about Sarah Langer. She's a 62-year-old woman with shortness of breath who presents to the ER. We're going to be working in teams of, I believe, 4 to 5 students to solve a patient case. And something to note is that throughout the case, you're going to be able to collect key finding stars. These are stars that are pertinent positives or negatives that will help you narrow your diagnosis. And every time you get a key finding star, that will equal 1 point. You'll also come across quiz questions, and anytime you get those correct, you will also get 1 point. And the team with the most points wins. Pretty straightforward. And we have multiple teams with the same number of points. Then the team that gets it the soonest will be the winner, and everyone on the winning team will get a free custom scrubs set.
All right, so hopefully you guys saw like how the Sketchy platform really lets you practice going from broad differential to narrowing sort of as you go with vital signs, the physical exam, and then sort of data you gather as you go along. Um, so even when you were starting the case, you know this that Miss Langer is coming in with shortness of breath and your vital signs. You get the sense she looks uncomfortable. Her vital signs are a little abnormal, but not so abnormal that you would say that she's like sick. You wouldn't, she's not fully differentiated, so you can't fully rule that out, but it at least doesn't seem like she's sort of imminently decompensating. Um, Shortness of breath has a very broad differential. And of course, we're not going to speak through each one of these, but it's just to say that with very limited information, you start out with a tremendous number of possibilities. And it's helpful, even before you start to sort of think about the specific patient, to think about what the most common causes are, because 95% of the time that will get you to a differential that includes the ultimate diagnosis. Um, and even again, before you've asked the patient questions, we had some vital signs that helped us. So, based on the vital signs, what do you guys think we could have ruled out or ruled in? I'll say that, her heart rate is a little elevated, 100 is right on the upper limit of normal. But it's also not so abnormal that you would think an arrhythmia, for example, is causing her shortness of breath. If you were expecting something like AFib with RVR causing flash pulmonary edema, or just sort of a low output state that would cause shortness of breath, you would expect that rate to be a lot higher. The oxygenation clues you into, maybe the fact that there's some gas exchange abnormality and that this is likely to be a pulmonary issue. So again, even before we've seen the patient, we can start to narrow down our differential or at least reprioritize what we think is most likely. And then sort of moving on to the differential, you can think about timing to sort of further narrow down the differential. Um, the acuity of her symptoms helps us say, it's not likely that this is going to be sort of new stroke in the absence of sort of concurrent symptoms, which we'll talk about. And chest wall abnormalities also unlikely to have developed in the last 2 weeks. So just a couple things that we can start to narrow down based on your differential and what you thought of as most likely, pulmonary causes, then maybe cardiac, you could really start to take a focused history. So asking about chest pain, any muscle weakness that would clue you into sort of neuromuscular causes of shortness of breath. And then any exacerbating factors for the shortness of breath. Our patient tells us that the shortness of breath is worse at night with activity, and then that they have some pleuritic chest pain. And pleuritic chest pain, it's not specific to one diagnosis, but does make you think about conditions that cause pleural irritation. So that can include, hemothorax, so blood in the pleural space, complicated parapneumotic effusions or empyemas, malignant pleural effusions, and pulmonary embolus. So even just asking these sort of initial few questions, we can start to hone in on just a few diagnoses. We learned that she has a cough as we go along, and then we ask her to describe it as well. So The hemoptysis is another really telling finding. There are a couple things here that can cause hemoptysis. I mean, in reality, we do get patients with pneumonia who have hemoptysis, but typically those patients also tend to be on anticoagulation. So, based on the information we've gathered, malignancy and effusion, um, and pulmonary embolus really seem high up on the differential. I should say pneumothorax can also cause pleuritic chest pain, but you wouldn't necessarily expect hemoptysis with that. So again, our differential helped us refine uh, our differential a little bit. Going along with our review systems, we sort of asked about things that would suggest infection, maybe to make those things less likely. Weight changes, so red flag symptoms for malignancies, for example, and then risk factors. So if you're thinking about your illness script again, and you think about malignancy being higher in differential, if you're thinking about pulmonary malignancies, you'd think being on the older side, having an extensive smoking history, maybe having a family history of lung cancer as well. So looking back on our differential, as I mentioned, we've been able to sort of refine the differential somewhat. Is there anything that you guys would be looking for on your exam based on the information we've gathered so far? Um, I'll say so, things that I would be looking for, knowing that we're thinking about malignancy, potentially a pleural effusion or PE. I'm going to be looking for evidence of a DVT, so I'm going to be looking for lower extremity edema. For PE, I'm going to be looking for evidence of right-sided heart failure. So that would include sort of like gross sort of volume overload, maybe jugular venous distension. If we have an effusion or pneumothorax, you might expect diminished breath sounds, and then either hyper or hypo-resonance to percussion, which we'll also get into in a moment. So for her, when you listen to her, she's got diminished breath sounds on the right side, sort of in the lower right half of the lung field. And then you notice a dullness to percussion. And then when you check for tactile fremitus, you notice that it's decreased on the right side as well. Um, with these physical exam findings, we can differentiate between things that you would expect to cause sort of decreased breath sounds generally. So with a consolidation, where you expect there to be like an alveolar filling process. Tactile fremitus will be increased, but you'll still have dullness to percussion. Whereas for pleural effusion, you'll have dullness to percussion, but decreased tactile fremitus. And then for pneumothorax, you'll have hyper resonance, which really helps you differentiate between sort of either normal lung or either consolidation or effusion. So again, sort of having your illness scripts and what findings you expect can really help you differentiate between these things as you're doing a targeted history and physical exam. We do our exam to look for evidence of volume overload. We notice that she has no jugular venous distension. We don't hear any murmurs or gallops to suggest valvular disease as a cause of her shortness of breath. And she's got a regular rate and rhythm, sort of supporting the fact that she doesn't have an arrhythmia either. Um, she has trace peripheral edema, but nothing that seems asymmetric to suggest a TVT. So, do we think that this helps us narrow our differential down at all? What I'll say is, we don't have evidence of right-sided heart failure, which makes a pulmonary embolus perfect. Yes, exactly. So, pulmonary embolus seems a lot less likely here. Decompensated heart failure seems a lot less likely. And then, the trace peripheral edema, makes something like a DVT causing a PE less likely as well, where you might expect asymmetric lower extremity edema. So now that we have sort of the sort of top diagnoses that are differential, what imaging and labs would you guys have sent to confirm the diagnosis? And is there anything else you guys would want to rule out with imaging or labs? We had some initial workup to start. We had a CBC and a BMP before we placed any orders. Was there anything that stood out to you guys looking at these labs? Great. You guys are calling out all the right things. Perfect. Yeah, so a couple things that really stood out. So as you guys mentioned, the hyponatremia is probably the most impressive of these. A sodium of 120, just thinking numerically about hyponatremia puts you in that severe hyponatremia range. And fantastic. The D-dimer was a great pickup. Um, a D-dimer in a patient with what this patient, with malignancy, can be elevated. So a D-dimer is not specific and truthfully is only really helpful when your pretest probability of DVT or PE is low, because often it can be elevated, but not sort of because of clot, because of systemic inflammation. So it's helpful when you have a low pretest probability, but for patients who are sort of in the intermediate or high probability range, you'll probably need to do the workup for PE if your suspicion is high enough. If your suspicion is low, but the pretest probability just sort of based on their sort of demographic information, the possibility of alternative diagnoses, is sort of intermediate. You might be shooting yourself in the foot with a D-dimer. But here it was helpful, reassuring that this was not clot. And then, yes, we also have a low hemoglobin here with an MCV of 82, so it's at the lower end of normal. I think, we may call it normocytic anemia. If we're a little bit lower, we would call it a microcytic anemia. You guys appropriately called out that a chest X-ray is a really important part of our workup here. Um, Looking at this imaging, how would you guys interpret it? And how does this inform the next steps in your workup? And based on this imaging, are there any circumstances where you would try to treat the patient before you did additional workup? So this is sort of a two-step question, a little bit of a read my mind, but actually a really important thing when you're a really important question when you're thinking about pleural effusions. So to sort of in the interest of time. All right, great. So you guys are noticing that there's clearly a large right-sided pleural effusion here. That's excellent. You have sort of this meniscus that suggests that this is a pleural effusion. And you can sort of clearly compare it to the left side where you see a sharp costophrenic angle. The sort of retrocardiac space is nice and clear. There's no opacity, no effusion on the left side. This is a pretty asymmetric effusion. Typically, an asymmetric effusion this large would warrant a diagnostic thoracentesis. Diagnostic and therapeutic. This effusion is probably the cause of her shortness of breath. And so doing a thoracentesis can both offer diagnostic information and also relieve her symptoms. Um, the second question here, a little bit of a read my mind question, but say you had, this patient with shortness of breath, and knew a sort of known diagnosis of heart failure, and they had bilateral effusions. You might think that, you have a systemic issue causing that effusion. And typically, the systemic issues are related to volume overloaded. So, liver failure, heart failure, kidney failure, what are called sort of the great edematous states. And in those cases, volume optimization before proceeding to thoracentesis is a reasonable first step. Because if you manage the patient's volume and the pleural effusions largely improve, then you kind of have your answer even before doing that diagnostic thora. So, great thoughts, everybody. So far, really strong work. Um, as you guys saw, Dr. Reed in the case gave sort of great feedback on the labs, which we discussed in some detail. And then these are the results that we got back. So we sent some iron studies, some urine studies to sort of better characterize the sodium, and then a thoracentesis as well. In real life, probably you'd remove more than 100 cc's, but I think probably what happened here is we removed more than 100 cc's, but we only sent 100 cc's to the lab. That's usually sufficient to send all of the studies that we need. How would you guys characterize this effusion? Awesome. Yeah, it's fantastic. So exudative effusion, love it. As a pulmonologist, you guys are winning me over right now. This is great. So a pleural effusion is exudative if it meets any one of Light's criteria. Um, which include a pleural fluid protein to a serum protein of greater than zero point 0.5. And I think somebody in the chat mentioned getting labs for Light's criteria, which was an excellent point. You actually need labs at the time that you're doing your thoracentesis to really make a good comparison. And that includes getting a serum LDH so that you can do sort of the pleural to serum LDH ratio greater than 0.6 is suggestive of pleural effusion, exudative effusion, and then pleural fluid LDH of greater than two-thirds the upper limit of normal for serum LDH is also compatible. You only need to meet one of these three criteria for the effusion to be classified as an exudate. I'll say there's also sort of separate diagnostic criteria for pleural effusion called the pleural fluid only 3 criteria that there have been sort of increasingly used. And sort of outside the scope of this talk, but if you're interested in reading about them, you actually don't need serum studies for the pleural fluid only 3 criteria. And rather than just using protein and LDH, it also looks at cholesterol. And so, I commonly use the pleural fluid only 3 criteria, though I also use Light's criteria. So if you're working with a pulmonologist and really want to impress them, mention the PFO3 criteria and look them up so you know what the cutoffs are. Can't go on to the next slide. And then what considerations did you guys have regarding the iron panel, cell counts, and then some of the additional pleural fluid studies, the pH and the triglycerides? Um, so, based on her iron studies, right, she's not iron deficient, right? She's got sort of low iron level, but a normal ferritin and a low total iron binding capacity, which suggests it's more an issue of iron use than it is of sort of absolute iron deficiency. Atypical cells in the cell counts suggest malignancy, though it doesn't confirm the diagnosis. You really need sort of full cytology to assess for malignancy. And then the pH clues you into the fact that this is an inflammatory process. It is not necessarily specific, though if you saw a pH that was low enough, I would say, lower than 7.2, that does really sort of raise your suspicion for a complicated parapneumonic effusion or an empyema rather than sort of any other cause of exudative effusion. And the triglycerides of 50 essentially rule out a chylothorax, which is defined by pleural fluid triglyceride value of greater than 110. Um, the differential for exudative pleural effusion is quite broad. Um, there are those that are related to infection. So parapneumonic effusion, complicated parapneumonic effusions, simple parapneumonic effusions, empyema are sort of the main infectious causes, though tuberculous infection of the pleura can also cause an exudative effusion. Malignancy, as we've seen in this case, can do it. And then there are a few others that are less common, but you may encounter pulmonary embolus. Typically, if it does cause an effusion, it's going to be pretty small, not large enough that you can tap, but if you do, it'll be exudative. It may be eosinophilic. Autoimmune disorders, chylothorax, uh, pancreatitis, and post-cardiac injuries can all cause exudative effusions as well. There are some less common ones that are mentioned here. I'll say yellow nail syndrome is something that we'll invoke, but is not very common. And then bilothorax is very uncommon as well. So good to keep on your differential, but when you're the differential building, really think about the most common causes and really focus your sort of history and physical on those diagnoses. We have some clinical pearls for pleural effusions here. Generally speaking, if you think the pleural space is infected, or you end up sort of doing your diagnostic thoracentesis and your lab suggests infection, you really do need to drain that effusion for source control. So if your pH is less than 7.2, if you have fevers and the effusion is really complex, that suggests that you really do need to fully evacuate the pleural space. maybe with a chest tube rather than a thoracentesis. A couple of other pearls, a very low pleural glucose suggests like a rheumatoid effusion, and a really high LDH is not necessarily specific for one type of effusion, but strongly suggests empyema, rheumatic effusion, or a malignant effusion over other causes of exudative effusion. Um, Adenosine deaminase is not specific for TB, but if elevated, does strongly suggest TB. Rheumatoid effusions, and I think effusions associated with lupus can also cause an increase in adenosine deaminase. So you also need, if you're concerned for tuberculous effusion, to send AFB or acid-fast bacillus culture and an acid-fast stain. And if you are concerned about malignant effusion, you really need cytology to sort of rule that in or rule it out. An initial cytology that's negative does not definitively rule out a malignant effusion. If it's negative, it needs to be, and there's not another etiology for the effusion, and you still suspect malignancy, you have to send cytology again. And if at that point the effusion recurs and you still don't have an answer, it's sort of your clue to proceed to like pleural biopsy, actually. So sort of more advanced decision making, but something that you may see discussed in the hospital when you have negative thoracentesis. You can have what are called pseudo-exudative effusions, so transudative effusions that look exudative, either because of a diuresis that causes concentration of the fluid or longstanding effusion that just causes pleural inflammation. You can sort of get an elevation in your LDH or your protein. Generally speaking, I see it as LDH anecdotally. I think because that is the more sensitive cutoff in Light's criteria, though it can be with protein as well. To evaluate for pseudoexudate, you can do what's called a serum to pleural fluid albumin gradient. So you subtract your pleural fluid albumin from the serum albumin, and a gradient of greater than 1.2 strongly suggests a transudate, even if Light's criteria are met. So you don't always send a pleural fluid albumin, but if you've done your thoracentesis and the studies come back exudative, but the story doesn't really make sense, you can sometimes add an albumin on to those labs by calling the lab. Um, and then it's just important to keep in mind, Contreras condition where two separate disease states can affect the pleura, and not to anchor too prematurely on a systemic process causing an effusion on both sides. So if you may have bilateral effusions in heart failure, for example, but also have a patient who gets a really bad, strep pneumonia and then an empyema as a result. So in that case, you may have an empyema on one side and then a relatively simple effusion related to volume overload on the other side. Thinking about how to treat our patients, I'm sorry, I know I'm over time. Am a little talkative and have a lot to say about pleural effusions. But really, sort of for pleural effusions and for exudative effusions, the primary treatment is treating the underlying cause, which in this case is going to be malignancy. Treatment of malignancy can lead to resolution of the effusion, but it can take time. So in the meantime, you may have to find ways to temporize your patients. How you do that will sort of depend on how quickly the fluid's reaccumulating. If it's reaccumulating very slowly, you may be able to get away with serial thoracentesis, even on an outpatient basis. Um, if your patient needs drainage more than once every couple of weeks, they may end up getting what's called a Pleurex or an indwelling pleural catheter or pleurodesis. These are sort of indwelling pleural catheter. It's like a little tube that they can go home with and drain on their own. And pleurodesis is a surgical procedure essentially, where chemicals are instilled in the pleural space that are supposed to cause inflammation and scarring of the visceral pleura down to the parietal pleura, which actually prevents fluid from accumulating in what would otherwise be a pretty large potential space in between the two pleural surfaces. And then for patients with non-expanding lung, VATs and decortication are possible, though with malignant effusions, that tends to be less of an issue. You can, if the malignant effusion has been, long-standing enough, still run into issues with trapped lung. I just wanted to highlight, an example of, self-directed learning with primary versus secondary sources. So, if you had a patient with rapidly recurring effusion. You were wondering, why we went for a pleurix rather than pleurodesis or vice versa. Going to the literature and finding the randomized control trials for how we make these decisions can go a long way in sort of enhancing your learning and showing to your team that you're really engaged in your own learning. So this was a trial that showed sort of similar efficacy between indwelling pleural catheter and pleurodesis. The indwelling pleural catheters did have less time in the hospital and fewer days in the hospital until death or 12-month follow-up. So this is really sort of where we as clinicians get our decision-making rationale. And so this is an excellent sort of way of learning how we justify our decisions and again, sort of showing your initiative in learning. On the other hand, secondary sources are a really great way to understand the frameworks for thinking through common problems in sort of a specialist respective field. So this framework or this diagram comes from the ATS guidelines on management of malignant pleural effusions. And guidelines or secondary sources often cite primary literature, and so are not only a good way for sort of contextualizing the primary literature and sort of developing or borrowing frameworks that are put together by experts in the field, but also sort of allow you to go back and sort of find those sort of landmark papers that led to the development of these frameworks. So all cases are included in Sketchy subscriptions. Hopefully you guys saw that the Sketchy platform is a very powerful way to sort of work on your history and physical exam building skills while also learning, great internal medicine and having a little bit of fun with it.
Yeah, and just to add on to that, we have more than 400 cases currently on the platform. There's a case for every microbiology, pharmacology, and pathophysiology lesson. And so you're more than welcome to explore it and really just test out more of these cases. We don't just have pleural effusions, we have so many other chief complaints that you can test your clinical reasoning on.
Do you guys have any questions?
And it doesn't have to be about the case, it could just be about
Yeah,
your
clerkships,
clerkships
anything.
or internal medicine, residency, like anything.
That so with this patient need antibiotics, that's a really good question. This is a patient, so their temperature was a little elevated. They gave you some like inclination that they were coughing, some suggestion that there could have been an infectious process. I think what would have likely happened in real life is this patient would have been started on antibiotics in the emergency department, and until you had culture data to suggest that they didn't have an infection, or until you had your fluid studies back that were less consistent with infection is the cause of shortness of breath, you'd probably have that patient on antibiotics. So say you did a therapeutic thoracentesis, you drained 1.5 liters of fluid, and the patient immediately felt better. I would really strongly support that the effusion was the cause of the shortness of breath. Maybe you would wait like 24, 48 hours for your cultures to come back, at least the preliminary results, and then you would sort of discontinue antibiotics early. So again, you might put them on up front because you would always rather sort of start early antibiotics than sort of delay antibiotics because there's with infections increased sort of adverse outcomes when you delay antibiotics, but you wouldn't also want to unnecessarily sort of continue them. So yeah. And then high yield diseases to study for internal medicine rotation. I'll say that there are a few conditions that you'll see very commonly on general internal medicine. Um, Heart failure is, I think, very common on general internal medicine. COPD as well. So very sort of good conditions to become familiar with the inpatient management of, as well as medical optimization, because we do that prior to discharge. If you are rotating on a subspecialty, so if you're at like a sort of tertiary quaternary center, you may have cardiology services, you may have a liver service. Learning about the management of conditions that are most commonly encountered in those fields can go a long way as well. So on a liver rotation, you might want to learn about, you know, autoimmune, not autoimmune hepatitis, like alcohol-associated hepatitis, management of chronic cirrhosis, spontaneous bacterial peritonitis. So again, for general internal medicine, thinking about like those most common um, conditions, and then learning about sort of antibiotic use or like proper antibiotic selection for suspected infection goes a long way as well. Um, and then for subspecialty rotations, just thinking about what would be most commonly encountered to the specialty that you'll be rotating with. As far as pulmonary hypertension work after fellowship, yeah, so this is not a straightforward answer. There are dedicated fellowships for pulmonary hypertension, and when people do pulmonary hypertension, they either come at it through pulmonology or cardiology. There are dedicated pulmonary hypertension fellowships, which, if you're at a place that does not have a high volume of pulmonary hypertension, for you to sort of work with as a fellow, you may want to do as an additional year of training. It's not like a boarded fellowship, so if you have very high exposure to pulmonary hypertension and you seek it out as a fellow, you don't always need to do a fellowship. So I, trained at two places with a very large pulmonary hypertension volume. And so I spent my third year sort of doing dedicated pulmonary hypertension work. But people come at it from different uh, angles or from different backgrounds. What exactly should we be doing when we pre-round? Like Miss Sarah, I feel like at times I would feel confused whether I should perform a physical exam on a patient who looks really sick or sleeping. And how should we present if we are confused with what we are hearing with auscultation? Um, this is a great question. So, if you were just examining Miss Langer in the morning before you were rounding. I also remember feeling I remember on surgery, I was pre-rounding at 4 a.m. and I looked at a patient from the door, they were sleeping, and I just decided not to go in, which is not necessarily what I recommend, but it's to say that, it can be uncomfortable to sometimes, wake someone up. Um, the hospital's not a super restful place. It's great that you're trying to be mindful of that. What I would say is for your patients who are sick, if you can delay your pre-rounding on them until you until like the very last minute to sort of minimize the chance that you have to wake them up. That's helpful. There's a lot of pre-rounding that you can do before you even go in the room. So you'll see on the EMR, you can collect a tremendous amount of information. You can prepare your note. You can run through your plan with your resident and then go speak to the patient. And maybe things change when you go and speak to the patient. But a lot of the time, a lot of the information that you need to sort of come up with an assessment and plan, or at least sort of preform your thoughts, will sort of be in the chart. On the flip side, doing that sort of in-depth review can also give you some contingency planning. Okay, so say, Miss Langer says she feels more short of breath today. That's going to tell me that maybe we should repeat another chest X-ray today. Or maybe we should come back after, on rounds with the ultrasound to take a look at her pleural space again. Um, and so, doing that preparation can sort of make it so that you're going to her a little bit later, reducing the chance that you wake her up, but also that you're going in with a sense of how you're going to use that information. Um, how do I get the most out of my internal medicine rotation? I think setting expectations with your team early on goes a long way. So you'll sort of it's intimidating at the beginning, but as you go along, you'll sort of realize that there are things that you'll want to work on. And so talking to your resident and your attending about your goals can really go a long way in helping you figure out, what you're going to work on over the course of your rotation. So maybe you feel really good about your history taking, but you're not so comfortable with your auscultation skills. This is where, setting the expectation that, I want to know what wheezing sounds like, and I want to be able to sort of confidently say whether wheezing is getting better or worse over the course of somebody's hospitalization. Um, can sort of lend itself to then when you're pre-rounding, if you're not so sure what you hear, you can be honest with your attending or your resident and say, I think I heard a little bit of wheezing, but it would be great to listen to the patient again with you and hear how you describe what you hear. So that, it's a team effort, because that is ultimately what it is at the end of the day. So I think setting those expectations with your team helps you get the most out of your rotation. Um, and then sort of doing that individual study as things come up that you don't know. Things you should be looking for in the patient chart. So generally, I look at vitals over the course of 24 hours, ins and outs over the course of 24 hours if you're at a hospital where ins and outs are well documented, any imaging that's been done, any labs that have come back, and any consultant notes from the prior day. Typically you'll be aware of sort of consultant notes, but maybe you won't. Um, sometimes they'll talk to your like resident, and you may not have been privy to that conversation, or they'll note will sort of go in later in the day, sort of after you would have left. So just looking to see if there were any specific recommendations that were made to follow up on. So those are the things that usually I'm looking for when I'm pre-rounding in the morning or sort of looking at in the chart. And then tips to prepare for internal medicine in medium-sized regional hospitals with no resources or consults available. That's intimidating, especially as a new medical student. What I'll say is, the internists in these hospitals, I think, get really good at doing a little bit of everything and sort of learning where they sort of pull their information from can go a long way as well. One of the best skills I think you can learn in those situations is what can be done at your hospital and, what needs to be transferred to another hospital. And I'll say that I still, when I'm, you know, you, if you train at a sort of large quaternary center, you take for granted things that can be done there that can't be done elsewhere. When I was at the VA for a year, even it was a VA with specialists, but there were certainly things we couldn't do there that we had to send people across the street to Penn for. So um, sort of learning what those things are, so that sort of what you can safely manage there before transfer, and sort of how to get that patient stable for transfer is probably um, uh, you know going to be important for your success. And then skills to focus on developing going into fourth year rotations for internal medicine. Um, if you're doing specific electives, this is where I don't know if you're doing sort of like general internal medicine electives or if you're doing sort of subspecialty electives. If you're doing subspecialty electives, really sort of engaging in the literature in that area and learning to sort of think like the consultants do in that area can be really helpful, because you're learning, on internal medicine, you learn to think about the patient holistically. As a specialist, you really think about a problem exhaustively and make very specific recommendations. And I'll say that even as an intern, one of the hardest things for me was becoming really specific with my plan building. So if you're on a subspecialty rotation, building that skill of learning how to say what you're doing with specificity goes a long way. Even if you're on a general internal medicine rotation, being specific communicates that you have really given thought to your plan. So, for example, if you have a patient with a GI bleed, rather than saying trend the hemoglobin, how often are you checking their CBC? If they're getting a transfusion, when are you checking it after the transfusion? When you say, establish good IV access for that patient, what does that mean? Do they have, a 16 gauge IV already? If they do, is it just that one IV? Where is that IV? And if you can't place one, what are you going to do to make sure that you have good IV access? So again, just thinking very specifically about the patient in front of you and the problems that they're coming in with, so that you can make sure that you're sort of delivering the most comprehensive care possible.
I think that's a pretty good place to end. We've seen the sunset behind Dallas, so
Sorry,
I know
guys.
it's I know it's getting pretty late.
All right. Thanks, everyone.
So
Have a good night.
thanks everyone.
All right, thanks, guys.